Hey everybody, this is another recording on health and physical for your adult patients, but this one is from your Med-Surg Hinkle book instead of from the Fundamental Tailor's book. So I'm not sure what Belinda's telling you, but I'm going to keep mine brief because I think hers is way more in depth. So here we go. The role of the nurse in conducting a physical assessment is to get a comprehensive health history, do a physical assessment, use the nursing process. So, your ADPI, assess, diagnose, come up with your care plan, set your goals, do your interventions, and then evaluate how it's going. Then use the electronic medical record to both review what's going on with the patient care or what's happened in the past and add the information that you gained from your collaboration with the patient and the care team. Effective communication is huge. If we don't have effective communication, it's hard to build trust, and without trust, it's hard for us to provide effective care to our patients. So we want to establish rapport, make eye contact unless there's a cultural reason why you wouldn't, listen to our patients, be aware of their nonverbal communication like pain, or maybe body language with other people in the room, or maybe they assume a defensive posture and put their arms around themselves when a particular family member walks in. That makes you want to question whether there is domestic abuse in that household. We also want to consider our patients' education and cultural background, of course. Their language proficiency and primary languages. Avoid using medical jargon, which I'm pretty sure as we get more versed in this type of career, it's easy to forget that not everyone knows all of the medical terminology. So try to keep it simple. You need to know the medical words, but try not to use them so much with your patient when you're explaining what's going on. Ethical considerations, keep it private. Don't answer information unless that person has permission by the patient or unless they are directly involved in that patient's care. Only offer the minimum necessary. Components of the health history include all of the things you can read right here. I don't think anything on there is something you don't know, but if it is, feel free to ask. I don't think I need to cover it. And one of our big things we're going to do is we're going to make a list of their current medications. So we're going to do what we call a med reconciliation. And we'll provide that to the physician or the nurse practitioner as soon as possible so that they can make a determination as to whether or not the patient will continue to take those medications while they're in our care. And look at that. There's holistic care right there, physical, spiritual, and interpersonal. There's the risk for abuse right there that I had just talked about. Do they have any disabilities? What's their self-concept like? How are they handling stress and how are they coping? And that's just not just your patient, but it could be your family members as well. So the physical exam, I think Belinda's talking quite a bit about that. But our general observations, you start observing from the second you walk in the room. You see the patient's posture and their movements. And when you're talking to them, you can hear their speech. We're going to check their vital signs and we're going to check for pain. And let's see what else is next. Our focused assessments. Yes. So skin, we said, is the largest organ. It tells us a lot about a person. So we want to do a very detailed assessment of our patient's skin so that we can see if we have concerns with nutrition, if we have existing injuries that need to be addressed, or if we are at risk for injuries. Neurologic, we're always having conversations with the patients to make sure that they're alert and oriented. ×4, person, place, time, and situation. Musculoskeletal, if you've got people laying in bed, you definitely want to do some range of motion exercises to keep their muscles and their joints and their bones moving. If you don't move, you're going to end up in having to go to skilled nursing for rehab. So we want to get them up and moving, or at least moving around in the bed. And then this is the order that we do our basic physical assessment techniques. You'll want to know this order. It will be, I'm sure, a question that you'll have to answer. And you'll also have to demonstrate it when we start doing the head-to-toe assessments. So first you're going to inspect, which just involves what it sounds like you're looking. Then you've got palpate, assessment of structures of the body with light and deep palpation, percussion, use of sound to examine different parts of the body and organs. That does take a long time to do. And then auscultation. And actually, it's not in the right order on this slide. So please note that 1 is inspection, 2 is auscultation, then palpation, then percussion. Why do you think we auscultate before we palpate or percuss? Think about that. And then there's some pictures of people doing light and deep palpation. I will tell you that we definitely do light. We do not do deep. Leave that to the doctor. Auscultation of the heart. We're going to learn all of the different positions and placements of your stethoscope to listen to your heart sounds and at the different valves and important landmarks on the body to listen to the different areas of the heart. We'll do the same with respirations. Your nutritional assessment, again, remember, skin tells you a lot about someone's nutrition status, especially when they're malnourished. You might have the fragile skin. You can see the person's ribs and other bony prominences if they are undernutrition or malnutrition as one of their risk factors or actual diagnoses. Obesity is one of the ones that we are really struggling with in our population now. And I think that is mostly because when I was young, now I am telling an old lady story, I would go out and play. Like, my parents didn't even know where I was. I would leave when I got up in the morning after breakfast and go play with my friends until the streetlights came on. And my parents really didn't come out and worry about where I was. So we ran around and we ate lunch at whoever's house we were at. And, you know, we didn't have so much obesity when I was young. But now everybody's afraid to let their kids go outside the door without having adult supervision. And kids are very much into video games now. Plus, we have 2-parent working families, or we have single-parent families, so no one's home cooking, so the kids are eating junk food while they're drinking a 2-liter bottle of Mountain Dew and a big bottle of Takis while they're playing video games. So their nutrition's bad, and their calorie consumption is just empty calories. So we have obesity as a concern. Obesity is the leading cause of a lot of illnesses, like diabetes, coronary artery disease, and cancer. So it's a pretty big concern, and we really probably should try to get a handle on that. Lifespan considerations. Remember, we're only focusing on our older adults. You want to do a mini nutritional assessment. Components of an assessment include body mass index and dietary data, your own clinical findings. This talks about calculating your body mass index. We're not going to spend a ton of time on BMI. But if your waist circumference is greater than 40 inches in males and 35 in females, you're putting patients at risk for diabetes, dyslipidemia, which is high cholesterol, hypertension, heart attack, and stroke risks. They increase. Here's some different labs that can be ordered to see what the status of a person is. Prealbumin and albumin are the best indicators or labs to tell you if someone has malnutrition. Serum ferritin and retinol binding protein, this is how they're doing. Are they anemic? Complete blood count, hemoglobin, hematocrit, white blood cell count, red blood cell count, electrolytes, we talked about that. They're important in maintaining health. and there's a tight range that they need to be within, and then urine tests. Clinical exam, all of these are indicators of nutritional status. Makes sense? Height and weight, skin, hair, and nails. Nails can be thin, or they could have lines in them when you're malnourished. If your nails are clubbed, then you're not getting enough oxygen. We know about skin already. Mouth, how's their teeth, tongue and gums. If you have ill-fitting dentures, you're probably not eating as much as you could or as well as you could, and maybe you have a risk for aspiration, or pretty much that's it, I think, aspiration. Mucous membranes, are they moist? Are they dry? Tells you hydration status. And next, dietary data. So if you're looking at someone's nutrition status, we want a 24-hour food recall. What are they eating in the last 24 hours? What do they typically eat? And what considerations do they have from a cultural or religious perspective? You want to work together with your patients and their families. So here's some factors that do influence nutrition. Don't really feel like I need to go into that too much. You can figure that out just reading it, I think. Limited fixed incomes, they're not going to be able to maybe afford healthy foods. Cultural influence. Some cultures are going to eat foods that are more, heavy in saturated fats. Like one that comes to mind is people from Mexico tend to eat things that have lard in them, like the tortillas have lard, and the beans have fat added to them. So sometimes we need to see if there's something we can do to modify the way they make it, but keep the same foods that they enjoy, so that they can continue to eat what they like, but maybe improve their cholesterol levels as they get older. Medications that influence nutrition. So I guess what they mean by that is some medications are going to decrease your appetite, or maybe affect the absorption of the nutrients from your food. And there's the definition of a cultural assessment, which we talked about in another video. So that's it. And this one's even shorter than my last video. Hope you enjoy that time back in your day.